Yeah, good evening, friends. Welcome to this Tuesday evening sessions from Yashoda Group of Hospitals related to the different topics of interest for the clinicians and the fraternity. So today we have one more interesting area, and this became a buzz word in the last post-COVID sessions, like we needing the lung transplant more and more frequently than before, and there is a lot of acceptance in this area. So we today will discuss about what about this lung transplant, what are the different fast tracking which we can do. And to actually take us through a live case, we have Dr. Sricharan, who is the transplant critical care specialist in Yashoda Hospital, Secunderabad. He will take us through that. And then we will take our expert panelist. We have transplant and thoracic surgeons, Dr. Balasubramoniam sir and Manjunath, and we have a transplant pulmonologist, Dr. Chetan. So to start the ball rolling, we will request Dr. Charan to actually take us through that case, and then we will take the expert panel opinion. Over to you, Charan.
Thank you, sir. Thank you for giving me this opportunity. So, good evening, friends. Today we'll be discussing about fast tracking in lung transplantation. Our experience with a case which we have performed recently for a patient who is having significant progressive fibrosing interstitial lung disease. So I'll go through the gist of what are the happenings of the case, and then we'll be discussing about what is the quality of life after a patient undergoes a lung transplantation according to the various guidelines. Coming to fast tracking in lung transplantation. So this is a case which I'm trying to present. So this is a 51-year-old male who had scleroderma-related interstitial lung disease. He was actually diagnosed with scleroderma more than 2 years ago, and he was been having interstitial lung disease, and he has been on chronic home oxygen therapy since the last 6 months. So his oxygen therapy initially started as 1 to 2 liters per minute with exercise, and then it actually progressed to a stage where when he presented to us, he was requiring oxygen as high as 6 to 8 liters per minute on rest itself, and then his oxygen requirement has increased to 15 liters per minute on minimal exertion itself. So it has been very difficult for him to actually get up from the chair, even go to bed and get up from the bed also. Each and every part of his activity, namely eating, walking around, everything became extremely difficult. So there was severe restriction of daily activities. He was completely wheelchair bound, then bed bound most of the times. And as I was telling you, he was requiring 15 liters per minute on oxygen with minimal exertion. So when he was actually presenting to us in the OPD, the minimum act of getting up from the chair and sitting in another chair is itself causing significant desaturations. So there were intermittent desaturations to 70s and 75%, and he was referred here for lung transplantation. So he was actually he came here with significant debility, and then he had episodes of febrile spikes, what we thought was infective exacerbations of interstitial lung disease. He was having some purulent sputum. He was having intermittent fever spikes. The cultures were growing bacteria, and upon appropriate antimicrobial therapy, his overall condition becomes a little stabilized, but his oxygen requirement did not actually come down. There was significant debility in his day-to-day life activities itself. So after he was referred to us for lung transplantation, he was evaluated completely for lung transplantations. Namely, all the blood tests, all the immunological profiles were done, and all the cross consultations and multidisciplinary meetings were done in order to actually optimize him for a lung transplantation. So because of his significant restriction of physical activities, there was significant loss of muscles because of his rather sedentary lifestyle, which was forced upon him because of his increasing oxygen requirement. So there were some degree of weight loss in the last 3 months. He lost around more than 6 kilograms of weight loss. So he was actually prescribed good he was prescribed nutritional optimization of the nutritional intake. He was actually got in touch with the dietitians. We were his BMI needs to be preserved for his post-operative rehabilitation, and with the help of our physiotherapist, graded physiotherapy was introduced into his daily activities, and he was actually able to do good performance of physiotherapy by the time he got a lung transplantation. So his exercise tolerance comparatively was better than before, but it was not as optimal also. So was on waiting list for the last 1 month, and then he underwent. We got a size matched as well as an immunologically matched donor, which was available, and he subsequently underwent a bilateral sequential lung transplantation here at Yashoda Hospitals 1 week ago. So these are the actual lungs. The intraoperative findings. Intraoperatively, the patient was, these are the lungs which which were explanted from him. You can see from their very structure itself how much damage they are, and there is no actually, no, it is not a surprise for us that he has a significant debility in his day-to-day activities given the condition of his lungs. There were even the CT scan was actually showing significant progresses, fibrosis with very low DLCO values and also FEV1 values. So intraoperatively, he had a size-matched and immune-compatible donors. He underwent bilateral lung transplantation. So given the status of both the lungs which were damaged beyond repair, the idea was that to go ahead and do a transplant on a central ECMO support, because he will not be able to tolerate a single lung ventilation during intraoperative course given the bad state of his lungs. So it was decided in the multidisciplinary meeting that he has to undergo a bilateral lung transplant on a central ECMO support. So subsequently, his RA and aorta were cannulated, and he has been on a central ECMO support during the whole course of the lung transplantation. The operating time was around 8 hours. It was the entire intraoperative course was excellent. There was no complications. There was no episodes of bleeding or anything. He had not required any blood transfusion so far. So he was set after the ECMO support, he was shifted to ICU after converting a central VA ECMO support to a peripheral VV ECMO support to support the lungs, given his overall poor status when he was operated. So his course on ECMO was relatively good. He was able to maintain his saturation. So we were keeping him awake all the time for him to be cognitively active. He was also on mechanical ventilator supports. So after fluid optimizations, and everything, his ECMO support with minimal ECMO support, he was actually able to maintain good amount of oxygenations. His PF ratios were consistently greater than 300. So given the good nature of or good improvement in his overall oxygenation status, he was given a wean of trial of ECMO, and subsequently he was decannulated off ECMO in 36 hours. So even after ECMO, we decannulated him of ECMO support, he was able to maintain good saturations and his PF ratios were consistently 300. And then he was given a trial of weaning of mechanical ventilation. And subsequently, at the end of 48 hours, he was extubated. And after extubation, we were able to start the rehabilitative exercises on the same day of So this is the patient. This is on POD3, actually, post 24 hours after extubation, he was made to sit on a chair. So after the extubation protocols, we were actually wanting him to be as active as possible because there was significant loss in muscles, and given the ECMO supports, he'll be requiring some degree of sedation and paralysis during intraoperative course, and also he'll be receiving steroids in the postoperative course. So we want his muscles to be as much active as possible so that he doesn't go into those muscle weakness. And as we all know that rehabilitation is the most important part in the postoperative course for a success of lung transplant. So this is him actually performing active cycling on POD3 itself. So you can see that his quadriceps and his muscle power of the lower limbs is significantly preserved. So he was given limb exercises as well as breathing exercises. So these were the limb exercises, active limb exercises with the help of our physiotherapists. So all the time during the whole course of physiotherapy, we were actually monitoring his saturations, and he was able to maintain good amount of saturations without any good saturation levels. There was no desaturation, and we can say that his exercise tolerance was reasonably okay. And he was also made to start on incentive spirometries. So this was all on POD4. So POD4 and 5, we made him start an incentive spirometry. We started him on active limb and chest exercises, and the plan was to make him walk as quickly as possible so as to expand his lungs. So this is on POD5 of the course, and we are happy to say that is actually probably the first step which he has taken in a very long time. So that was with minimal amount of oxygen support, hardly 1 liter oxygen support, and then and then subsequently he was able to walk without an oxygen support also. So right now, that particular patient, he's walking with support, he is off oxygen, and he's on a regular oral diet. So needless to say, he's significantly happy right now, and he's on a path to a new life. We should say that, because given the way he presented to us and given the way he is right now, we can say that he is actively on a path to a new life. So what are the factors which has affected, or which are the factors which affect the adequate rehabilitative recovery of this patient? So it is one of the most important things which we should be considering is a preoperative rehabilitative potential. This preoperative rehabilitative potential, that is the reason we actually spent a lot of time and effort in improving his exercise tolerance in spite of him having significant high oxygen levels. So he is requiring more than 10 liters oxygen levels also. that is not an excuse for him to be sedentary. So because his preoperative rehabilitation potential is what directly determines the postoperative rehabilitation and postoperative recovery of this patient. So even though we transfer the lungs, it is his musculature which has to support the entire new pulmonary tree which is present, pulmonary system which is inside. So he should be able to expand his own lung. So there is preoperative rehabilitative potential and adequate nutrition and maintenance of the basal metabolic BMI preoperative. So he was actually under the constant vigilance of the doctors and the nutritionists to actually maintain good nutrition and maintain good BMI preoperative, because surgery being a very catabolic state, so he is expected to lose some weight and he is expected to get into some degree of malnutrition post-operatively. So in order to prevent that from happening, in order to not let the malnutrition go into beyond levels, into the levels where his rehabilitative potential is influenced. So we want to make sure that there is adequate nutrition and BMI preoperative. So there are certain things called the primary graft dysfunction, which typically occurs because of the ischemia reperfusion injury when a newer lung from cold ischemia is actually implanted and it is unclamped. So when the recipient blood perfuses the donor lung, there might be some degree of endothelial dysfunctions and also some degree of pulmonary edema-like picture, which can cause ischemia reperfusion injury. So this is called the primary graft dysfunction. So there are various factors which actually influence the primary graft dysfunction. All the efforts were actually made to decrease the incidence of primary graft dysfunction in all these patients. And last but not least is early postoperative physiotherapy and mobilization, which we have started, needless to say, before extubation. The initial chest and limb physiotherapies were started before extubation, and immediately after extubation also, he was actually active physiotherapies was done in order to mobilize him. Now, this is actually an article which actually compares the extent of physical activity levels early lung transplantation with that of their pre lung transplant levels. So we can actually say that in the pre-transplant levels, this is actually with a sample size of 36 people from Toronto actually. So in these pre-transplant levels, we can actually see that the daily steps which a pre-transplant patient managed to take were around 2,856, which has increased significantly at the end of 3 months, and at the end of 6 months, he was actually able to do double to that. So he's almost doing around 4,859 steps per day. So the time in moderate activity, the amount of time he's spending on moderate activity is also significantly increased from 7.2 minutes per day to 19.2 minutes per day. So his wear time has come down. That is from 14.2 hours to 13.7 hours. So everything is actually almost reaching normalcy at the end of 6 months post-transplantation. So these are the findings of the 6-minute walk test before and after transplantation for the same sample size. We can actually see that the amount of distance where a patient is able to walk in the first 6 minutes, it is around 383 meters in the pre-transplant patient, but it's around 510 meters in the 6 months post-transplant. So everything, the end test saturations, the end test dyspnea levels, the end test fatigue levels, and even end test respiratory rate, everything has improved. And by the end of, you can actually see at the end of 6 months, it is almost coming to normalcy. There is no patients who are actually requiring oxygen at the end of 6 minutes walk test in a patient's post-transplant at the end of 6 months, whereas in pre-transplant, he was actually almost 34 patients were requiring oxygen support. So this is also the health-related quality of life indices of the very same sample size of 36 patients post-transplant. So we can actually say that at the end of the physical function, and the interesting part is that the last column. So if you actually compare how are the patients in the pre-transplant and how are the patients at the end of 6 months, we can say that their overall health-related quality of life has improved. So the physical function, which was 23, has come up to 82. Bodily pain has come, vitality has increased from 38 to 70. So that is, we can expect some degree of improvement in the health-related quality of life before and after transplant. But what is interesting is that if we actually compare it to the general population norm, it is comparable. So we can actually say with reasonable confidence that these patients at the end of 6 months almost reach the normal population level. So if you see that the patients in physical functions, 82 is clinical function, 86 is the population norm. So even general health, vitality, social functions, mental health, everything. In fact, you can see that these patients are all of these parameters which we are comparing in a SF36 model of health-related quality of life. We can actually say that it is comparable at the end of 6 months to a normal population. Thank you.
Yeah, thank you, Charan, in bringing that case and updates. I think till the recent years, the lung transplant became not a easy task in this part of the world, and it's been in the evolving stage of availability. But I think in the last decade, or the end of this last decade, there was a lot of awareness, and there are a lot of, I think, advancement happened in this area, and we could actually see lung transplant became a reality in this part of the world. And for this to bring, we are glad and is honored to be a part of this program, where we actually able to invite Dr. Balasubramoniam sir. Sir, welcome you here. It's an honor for us to make you available here. And Dr. Manjunath Bale, sir, can you just switch on your camera? Yeah, and so both Dr. Balasubramoniam and Dr. Manjunath Bale were the surgeons who were involved in this case in operating, and Dr. Chetan was the man behind as a transplant pulmonologist in this case. So just to actually make the whole idea of this program is when these patients with an end stage lung disease who are disabled with this daily activity and daily life, either they actually reach out to a pulmonology, or someday or other decompensates and finally lands up to one of our ICUs. And they will be struggling in many situations for her life. As Dr. Charan said, some of these patients will be lucky to get stabilized and go to a rehab center, and they come back for a transplant. So this is just kind of a eye opener in many situations, where many of us as an intensivist or a pulmonology colleagues wanted to get the first-hand experience from all of you. To start with, Dr. Chetan, what are the challenges in Indian context? For example, over the last 2 decades or so, we have not seen many transplant. In recent past, we have seen some of them happening. What is the main challenge in Indian context? Unmute yourself, Dr. Chetan. Avan, can you make it main screen? It's still the slides presentation. Stop the slides sharing, Charan. Yeah, Chetan, unmute yourself. Yeah.
Yes, sir. So I think this is a great point to start the discussion with. So our cadaveric programs, especially when pertaining to lung transplant, were never so successful. It's majorly because of various religious beliefs and taboos that we have when it comes to organ donation. But thanks to this state level, national level organ donation organizations, which are creating awareness, and slowly the organ donation rates are building up. So according to the organ donation data from 2019, the rate of organ donations in India is only 0.52 per million population, as compared to 37 per million population in the USA. So we are way lag behind when it comes to organ donation, which is a major challenge in running a transplant program in our country. And like institute like us and everyone is still trying to promote or bring awareness about organ transplant and organ donation and transplant on the other side. So we have challenges at every level, be it donor, we have challenges at the recipient level, we have challenges at the infrastructure level also. So when it comes to the challenges at donor level, so the availability of lung for transplant is very low. At the same time, the waiting list mortality in lung transplant is somewhere around 10 to 20%. And of all the organ donations, the selection of lungs for transplantation varies only from 10 to 20%, and most of the lungs are rejected because we try to go around the ideal donor criteria. And whenever we don't find a donor that fits into the ideal donor criteria, we go with the extended donor criteria. So to overcome the shortcoming of organ shortage, we have now come up with extended organ donation criteria, and that is improving our transplant rates, and which more or less is coming with equal success rate when carefully managed in experienced centers. And when it comes to the recipient level, most of the patients are referred to us very late in their disease course. Like, let's say this particular index course, he was referred to us when he was already requiring 5 to 7 liters of oxygen, which progressed to 10 to 12 liters even on slightest exertion. And as Charan sir said, he was predominantly wheelchair, chair-bound or bed-bound. We, after evaluation, tried to motivate him a lot for rehab, but he was not willing for it due to various reasons. So, to be very frank, lack of physical activity pre-transplant is a risk factor for poor survivals post-transplant. But luckily, at least this patient's lower extremities had preserved muscle. That's the reason we could still go ahead and do a transplant. And second thing, we wanted to preserve his BMI as much as possible despite the limited physical activity. And recently, he had an infective exacerbation 2 weeks before the transplant. So even then, we tried to avoid steroids as much as possible. We treated him only with antibiotics as per the culture sensitivity reports, and luckily we could get him out of the infective exacerbation. The whole point is to preserve his muscle mass and functional status as much as possible pre-transplant. This happens when a recipient is referred early in the disease program when they are functionally preserved. So for this, probably we have to create a lot of awareness in the referring physicians, pulmonologists, and all the respected specialties.
So you are trying to more specifically talk about that the lung transplant needs a cadaveric donor. So the donor was a major limitation factor, and then you comes as a ideal lung for a recipient, and there you also are now using extended things. And from the recipient side, the delayed kind of referral, is that happening because of the awareness, or there are many other factors which are playing?
So probably one thing is there's lack of awareness on both the sides, on the patient side and also on the treating physician side. To be very frank, lung transplant programs got their pride only after COVID. Thanks to COVID for that. And there's significant increase in the awareness after COVID regarding transplant. So even most of the treating physicians are not aware of existing transplant programs in the country, which we are slowly trying to build up. And even though the treating physician refers a patient for a transplant, the patient would not land up with you. First major concerning factor is cost. In developing countries, not only in India, in any developing country, cost is a major factor that decides a patient's outcome. I hope everyone obeys with that.
Yeah, there are limitations with the cost affordability in many sectors of it. Balasubramoniam sir, we do understand the complexity of lung transplant in the Indian context. As a surgeon, what are the challenges you believe this lung, which as a critical care specialist, we are very skeptical about this organ because of its epithelial lining, its exposure to the world. So what is the challenges you face as a surgeon when you transplant these organs?
So thank you, Venkat, for all of the introduction so we had an opportunity to do a transplant last week. So see, intro of the main problem we face is pulmonary hypertension. So these patients who are ILD, they have a small chest cavity. And they invariably have pulmonary hypertension too. So once they have hypertension, when we start doing a hilar dissection, we see either they become unstable, so that they become hemodynamically unstable. So when we go on one lung ventilation too, they may become hypoxemic, depending on which lung has a more VQ ratio. So there we use a strategy of elective planning and the VA ECMO as a mechanical circulatory support. So when we plan VA ECMO as the support, the advantage there is they don't become hypoxemic. They maintain hemodynamic stability all along. So the advantage there is post-op to they remain stable. They don't have any kidney or liver injury because their hemodynamics is excellent intro. So another important thing is we don't have hypoxia. So we can truly concentrate on operating. We are not really worried about the fluctuating SPO tools. The third factor would be we are able to do a controlled reperfusion of our first lung. So we always see and we don't use elective VA ECMO. There is a high chance of having what we call the first lung reperfusion syndrome. So that contributes directly to PGD in that lung. So when we use intraoperative VA ECMO, we are able to give a controlled reperfusion to a first lung and subsequently to a second lung too. We do have studies now clearly saying, including a paper from Vienna, where they studied some 160 odd lung transplants, all on elective VA ECMO, where their PGD rates were as low as 1.3% in the first 72 hours. So we don't have a clear randomized trial showing CPV versus ECMO, but we do have studies clearly showing the advantages of an elective intra-op VA ECMO. So that's one area. The second area would be how it contributes to your post-op recovery. So obviously, if you don't have hypoxemia and hemodynamic instability in the post-op period too, you don't have an AKI, you don't have AF, patient remains stable all along. So we also see that it counteracts or supports in the event of a PGD2. So you don't we really have to have a PGD and then go in and have ECMO on. So in this particular situation, I really feel VA ECMO helped. And you can see how he recovered. By day 1, by 48 hours, he is off ECMO. By 72 hours, he is off elective ventilation. By day 4, he is cycling, and by day 5, he is ambulating. So as the sort of recovery we can expect if you have a smooth intraoperative period.
So you're very specifically saying taking a support of VA ECMO helps you, gives you extra space, and the safer the surgery and the outcome and a quicker recovery, which you're trying to say. Dr. Manjunath, any points from your side? You have been doing a lot of thoracic work. I think the lung being your... Manjunath, are you there? Pawan, Dr. Manjunath got disconnected. So, Dr. Balasubramoniam, there are a lot of thoracic work which is going on from your side and all. So, there is a lot of even your bronchial tree work, tracheal work, thoracic work. But how complex it is when it comes to transplant? Is it more challenging? How the whole world probably is this is one of the complex thing or a transplant which the whole world looks into. So, how different it is?
So the difference technically would be the complexity and the duration of the procedure. So first we have to take a donor lung. We have to go and do a donor lung harvesting. We have to make sure the graft which we are using, the pulmonary allograft we are using, is very excellent. PCR, ABGs, pre-op bronch. We use all the criteria, including intraoperative assessment, to make sure a donor lung is excellent. So once that's harvested, stage 1 is okay. Then we come into a recipient where the challenges in thoracic, we deal with people whose one lung is damaged, but the other lung is okay. Here we are dealing with people where bilateral lungs are out. So they are more hemodynamically unstable, more hypoxic. They don't tolerate lung so well. So that's one challenge. Two is doing a pneumonectomy in IELD patient or in a bronchitic patient where they have had infection for so long, like in bronchitis, where you have had infection for so many years, they may have more bleeding interop. So all our skills as a thoracic surgeon comes into play there. We have to do an excellent pneumonectomy without bleeding. And we go on to implant the lungs. So there we use, we have a challenges of, as I told, only hemodynamic instability. We retract the heart more, especially when we implant the left lung. So there that's where mechanical circulatory support like a VA ECMO helps to maintain the hemodynamics. So it's a new area, but we can't say it's an entirely new zone. We are used to, operating in that area, but newer challenges are there.
Yeah, Dr. Manjunath, we were discussing about, you have been all handling a lot of thoracic areas over the years, but how complex are the transplant being a part of it? What are the challenges we generally face? And he was already discussing about getting a support from a VA ECMO. So,
Yes.
So what is your take on that?
Sir, the major challenge when compared to any other thoracic surgery for a lung transplant is the anastomosis itself is technically challenging because of the depth of the anastomosis. The anastomosis is deep, almost underneath the heart, and you are doing it in a semi-lateral position. When we do a thoracotomy for a pneumonectomy or a lobectomy, we do it in a lateral position. So the access to the hilum will be more direct, and the anastomosis also can be more direct. But when you're doing a transplant, you're doing a sequential transplant, we are doing it in supine with slight tilt of the table, and we have the anastomosis underneath the heart. All the vessels come from below, so that makes it more difficult and more challenging. And most important thing here is the margin of error is very less. You cannot have a complication on table like bleeding or a small leak where you have to take multiple bites. Any extra bites is a source for further complication in the post-op period. So that's not the same when you do a normal lobectomy or a pneumonectomy. You have a little bit of margin of error when compared to a transplant patient.
So there was some discussion from Chetan also that you also extend the criteria for donor. So as already Dr. Balasubramoniam was talking about, you always see these patients who are actually ILD, the thoracic size gets compromised, and you need to adjust these lungs. So what are the challenges? How frequently we face that? With one side, we have a limited donor availability, and the other side, we have the mismatch issues.
Yeah, so if there is a mismatch where the small for size is large for size is what we call it. If the lung size is large for the chest cavity of the recipient, what we do is we staple the part of lower lobe so that we size match the cavity and the lung, the donor lung, so that we don't have a very huge lung sitting in a small cavity. So we take part of the lower lobe using staplers to divide that part, and we anastomose the rest of it.
Sricharan, you being a fortunate, Sricharan, can you be Sricharan? You being a partner team member in Yashoda Group, see, as everybody was pointing out, Chetan and everyone, availability of a donor has been a challenge across the world, not just in India. Even we may have a, what I would say, slightly criticism about the developing world, but even the developed world, there is a lot of challenge in availability of organs. So in that sake, you should actually feel privileged to be in Telangana, where the Jeevandan has came into a big rescue, where we are leading the India. And in that angle, you also be privileged to be in Yashoda Hospital, which actually could actually produce a lot of motivation to the cadaveric donor. So what was your take? So the position of being in the city, being in the Yashoda Hospital, what was your experience of making availability of the cadaveric donors
So here in Yashoda Hospitals, we have a very good
program?
yes, very good program, sir. So it's actually a very proactive things. People, there is good amount of awareness, and thanks to Jeevandan, also there is a very good amount of awareness in the overall population here regarding the organ donations. And also we have a very proactive program where there is organ
How
donations
frequently you get the organs in a month, in a week? It may vary, I do understand, but what is the frequency of the organs availability?
We can almost, like, there are times we have almost had up to 2 to 3 organ donation calls per week, sir. So that's actually a very good number of organ donations. I am sure that there is no center in in India which has got as much as donor organ support, donor supports as Yashoda Hospitals has. So we have actually, there are places where we were able to do lung transplants significantly in when it's just a matter of the availability of the availability of a very good, as I was telling, size matched immune matched lung. There are recipients, and we can actually expedite their transplants because of the wide availability of donors, especially in Yashoda Hospitals.
Dr. Manjunath, we actually do a transplant in the OT. That too, I think it takes around 8 to 10 hours of a very long surgery.
Yes.
And after that, you also were talking about the patient on ECMO. You need a long process from that to
Exactly.
could see actually in a couple of days, your patient is out of mechanical ventilation, and in a day he was moving. So what is that takes or how many team members? What are the departments? How do actually this transplant team works?
So the transplant team starts with the transplant pulmonologist, who is the first person most commonly in touch with the patient, because he is the primary contact with the patient. Then once he evaluates the patient and feels that the patient is a prospective recipient, then the transplant surgeons are involved. There are other ancillary departments like physiotherapy, anesthesia. Most important is the critical care team. This is not a one man show or one surgeon's job or a group of surgeons' job. It's a whole team which is there. We sometimes see patients who are come on ECMO to us. So once the patient comes on ECMO, that means the primary department which is involved is the critical care team. Once they are able to stabilize the patient or at least make him fit for a transplant, only then a surgeon's role comes in. So
Yeah.
it's a very yes.
Yeah, Manjunath and Balasubramoniam sir and Chetan. Actually, we can see that what was happening in the last week or so since this patient got a donor, and
Yes.
the whole team, as I could see in that group, that actively participating from each side, suggesting, guiding, taking consensus. As you said, from surgical team to transplant pulmonologist to anesthesia team, intraoperatively perfusionist, ECMO technicians, nursing departments, physiotherapy, respiratory therapy, critical care, whatnot. So including housekeeping, the whole team, I could see there are 2-3 housekeeping team with the full gown supporting, helping, ambulating, physio. So it's a kind of a bonding created there. So probably that makes the whole story. But the other side of the story is once you do the transplant and these patients come out of the transplant at the discharge time, what are the challenges we do face with them?
So the main challenge is if the patient has a lot of weight loss and if he has muscle loss in the preoperative period, the whole respiratory mechanics are compromised because of the poor respiratory effort due to muscle loss. So our aim should be proper nutrition, early ambulation, and ensure that he doesn't land up in any acute events of rejection. Because every event of acute rejection will compromise the long-term longevity of the lung, as well as it will prolong the hospital stay and the myopathies associated with it because every time he has a rejection, we give steroids, which further increase the chance of myopathy, which further will worsen his respiratory effort, will further also reduce the longevity of the lung.
Dr. Chetan, all the other organs we can hide inside. Your heart is deep inside, your liver can be covered with your abdominal walls. your renal system is deep inside, but the lung has been exposed 20 times a minute to the atmosphere. So what are the challenges you face as a transplant pulmonologist with these cases, and how do we actually, they are different in Indian context?
Sir, as you said, lungs, when you transplant, they're like two huge organs with large surface area when compared to any other solid organ, and they're in direct contact with the atmosphere. So the first more dreaded complication immediate post-op is primary gut dysfunction, which in this particular case we would successfully overcome. And the first week to third week, there is risk of infections from the donor lung or the recipient colonized pathogens. So after that, from first week to third week, there is a high risk of opportunistic infection. And it is proven that in developing countries, the mortality of post-transplant patients is mainly because of infective complications. In the Western world, as you compare, it is mostly because of rejection, but in developing countries, it is most because of infectious complications. That's because of our population, overcrowding, and lack of awareness amongst the caretakers when they're discharged.
What are those guidances? What are those do's and do nots you talk to the family in these situations?
So this thing starts even before the transplant. So there is a schedule of vaccinations that we advise the patient even before the transplant, because at least post-transplant 1 year we will not be able to give any live vaccines or live attenuated vaccines because of the immune suppression. So we advise them to complete a schedule of vaccinations which include whatever is available as per the adult vaccination guidelines. And we also advise the caretakers to take advised vaccinations like flu and pneumococcal as and when required. And post-transplant, it is more about personal hygiene, sterility, not being exposed to the crowds as much as possible, at least 1 year post-transplant. And this, we are trying to create awareness among the caretakers, first family members, and the patient even before the transplant. So we tend to have bi-monthly consultations with the patient and families, either in person or on video call. And every time we focus on vaccinations and infection prevention protocols. Because rejection, they have nothing to do. It is all done by us. Whatever they can do is nutrition, rehabilitation, and infection prevention.
Okay. Coming back to Balasubramoniam sir, what are the prospects you are seeing in the field of lung transplants? We do understand the awareness is still not been optimal across, and also the awareness related to the availability of the transplant teams, availability of the transplant centers. The success rate has always been under the scanner. The complexity of the procedure, post-operative complexities, where Chetan said it is exposed to the atmosphere. With all these into context, what is your futuristic view of a lung transplant program in India?
So see, world over, we see around 4,500 transplants a year. That was a number that has been shown in 2016. Now in India, we were slow starters. But COVID really has, it's really promoted the way people see lung pathology, lung failure. We all know about ECMO now. So it has really been promoted the lung transplant scenario in India. So we have seen many hospitals come up with their own transplant program. So you can't really have an ECMO program without an active transplant program, because if you find that people do not come off ECMO, they need to be considered for a lung transplant. So it's invariable that you have to have a lung transplant program in a center where ECMO is also there. So we are going to see a number of owners come up. Our numbers too are going up. Like we have done around 35 lung transplants in the last 2.5 years. So that itself is not a small number as far as India is concerned. Our start has been excellent, and we expect to do more, lung transplants in the future as awareness goes up.
Yeah, Dr. Chetan, there are questions to you. How frequently you do bronchs in these patients after the transplant?
So the frequency of doing bronchoscope depends on individual centers, sir. Every transplant center has their own protocols. So as I said, in India, everything comes with a cost. So we have some tailored approach based on the patient. So ideally, we do a bronchoscopy on table before shifting him to the ICU. And once before extubation to do a thorough toileting so that he'll be able to breathe normally after extubation. And 2 weeks, 1 month, 3 months, 6 months, and 1 year. This is a protocol that we are following at our center. And in between, as and when required, like if you see a collapse in an X-ray or if the patient is unable to expectorate out, or if there's a dilemma of infection versus rejection. So we keep an extra bronchoscopy. And after 1 year, it all depends on the clinical status. If the patient is clinically symptomatic or if there is a drop in pulmonary function test, then we go for evaluation. So till 1 year, we have a protocol, and after 1 year, it is all patient-driven.
The other questions related to our, what were the common indication in Indian context right now? We do understand COVID fibrosis was one of the areas at that time, but what are the common indications you come across?
So currently in India, it is more of ILD and bronchiectasis, especially post-tubercular bronchiectasis. When compared to the Western world, where COPD and cystic fibrosis are predominant, for us it is ILD and post-tubercular bronchiectasis.
Okay. And how frequently you come across graft rejection, as you said, primary graft dysfunction, or what is the frequency where you come across?
Sir, a primary graft dysfunction world over data, it ranges from 20 to 30%. And PGD3, it comes with a 50% mortality in the first 1 month.
So Charan, any inputs from your side? You have been seeing a good number of transplants happening at your center. So what was your experience with the primary graft dysfunction? How frequently you have come across?
So primary graft dysfunction, the incidence of primary graft dysfunction in our like scenarios is not above the world standards. We have actually seen primary graft dysfunction in almost like 9 to 10 patients in all the 35 patients which we have transplanted so far. So the incidence remains still around 30 to 35% of primary graft dysfunctions. And right now we like it also depends upon various patient-related factors, donor-related factors, like and intraoperative related factors, which can predispose more to a primary graft dysfunctions. So, like a prolonged mechanical ventilation of the donor, or if the patient is significantly sick preoperatively, so that he is requiring venous ECMO supports, and sometimes as sir was as Balasubramoniam sir was as initially pointing out that the first lung syndrome or first lung reperfusion syndrome. So these are the most of the causes which we have seen primary graft dysfunction related things. So we have actually the PGD3 requiring ECMO support. We had a couple of patients who had significant primary graft dysfunction, so as much requiring post-operative ECMO supports. But these people have come down. Typically, these primary graft dysfunction, we need to stabilize the patient during the first 72 hours, and after 72 hours, the incidence of PGD is almost zero.
There are questions related to the fellowship programs in transplant anesthesiology. I think it's a waiting period. What will be the approximate cost concern? I know it varies with different situation, but the range, approximate range, Chetan or Dr. Charan, who can answer that?
So, I mean, we describe the cost in 2 parts. Sir. We do a pre-lung evaluation, pre-lung transplant evaluation, and transplant per se. So, pre-lung transplant evaluation comes with a set of investigations, which, like at our center, they're charging around 3 to 3.5. And the transplant, actually, we can decide the cost of transplant after the pre-lung transplantation. We'll get an idea how risky is the patient for a transplant, if he'll require an ECMO based on his pulmonary artery pressures and all. So it varies between somewhere around 25 to 35, and it's all tapered according to the patient.
So it will be also depending on the patient's needs and requirements and the institutional support and all that. So this is very interesting question. See, in Indian context, when we get all these donors, they come from the ICUs with the polytrauma, and that is the trauma is the most commonest organ donor, the polytrauma or brain dead situations. And they are ventilated in an intensive care unit, and you do see many of these patients do grow organisms and they come across infections related to the VAP. And then again, when you bronch during your transplant period or a post-transplant, you grow them. So that's, I think, one of the complex and challenging situation, which is peculiar to the Indian context, where antimicrobials were been abused, and we see more of resistant organisms. So how you are dealing? What is the donor bronchoscopy and the ball samples yielding and all that?
So as I said, we have ideal donor criteria and extended donor criteria. Our waiting lists are not as bad as the Western counterpart, but still we are trying to get an ideal donor as much as possible. So first, when we get a donor call, we look at the age, PF ratio, cause of brain death also. And as you said, if it is an RTA, we look for if there was any pneumothorax or hemothorax or fracture or any lung confusion. So ideal donor should not have any patch on the X-ray. And if there's no patch on a CT, or there is a suspicious patch on CT despite having a good PF ratio, per se more than 300, we go do a bronchoscopy. Central secretions are inevitable. The more prolonged ventilation, the more central secretions. Once you suck out the secretions, if you still see secretions pulling up peripheries, we tend to reject the lungs. Only after you do the central secretion, you suck out them and they're not pulling up again. And if the PF ratios are good and the lung count is good, you can still go ahead and accept the donor lung. And when we do a bronchoscopy, we send the bar for bacteriological workup, fungal, and tubercular workup. And post-transplant, if the culture comes positive of the donor, we guide the antibiotics as per the culture sensitivity reports.
Sharon, what is your complexity? I think it's not an uncommon situation in many of our ICUs where you grew organisms which are XDRs, and we were in the fix of treating them.
So actually, the donor secretions, the ideal things which we are doing right now is we are actually using multiplex PCR so that they have a very low turnaround times when it really comes to the organisms which are actually present inside the donor. So that actually helps us in tailoring the post-operative antimicrobials or intraoperative antimicrobials for that matter. And even because the international guidelines also say that to initiate patients of lung transplant on broad spectrum antimicrobials, that is what we typically do. We initiate patients on broad spectrum antimicrobials and we actually wait for the culture sensitivities to happen. And based on culture sensitivities, if the recipient is not showing any signs of infection, and if the ball samples which we have taken intermittently were not going, or if they are sterile, we can always de-escalate our antibiotics approach. So yes, sir, the XDR organisms in the intensive care units typically actually poses a problem, but we also take it with a pinch of salt that if there are no active consolidations, if it is just coming out of the secretions, we tend to wait. So we can always wait. But if, as Chetan was telling, if the patient is actually having significant pooling of secretions and if there is consolidation which is developing on the CT or X-ray, then we tend to hit it hard.
Dr. Manjunath, there are questions related to, we spoke about the specialized physiotherapy. You can unmute yourself. So I can also see your patient was cycling on the bed and has also been very early to be mobilized. So is there any specialized, you spoke about the muscle index or the muscle mass, nutritional status, early physiotherapy, and you also spoke about the respiratory strength and muscles. So any specific physiotherapy is the question from the audience.
So it is individualized therapy based on the preoperative assessment of the patient. How has been his overall performance status before that, even with oxygen therapy, whether he has been able to do any breathing exercises, whether he's been able to walk around with the oxygen intact. So based on that, we channelize their whole physiotherapy program, sir. So we have a full set of people who take care of that. So it includes cycling, walking with support, walking without support, and spirometric exercises, deep breathing exercises. All that we gradedly we start and then we progress based on his tolerance.
Any final comments, Balasubramoniam sir, to conclude the sessions from your side?
Yeah, so I really feel India is going to explode soon as far as lung transplant numbers and centers are concerned. Of course, we have a long way to go. And I really hope India comes on top as far as the number of transplants are being done. Our country really needs around 10 to 15 great lung transplant centers. So I hope it happens soon.
So, how many patients on ECMO lands up requiring transplant? Any specific marker to start illness hinting that this patient may require transplant? This is one question to the panelists. Charan, you want to answer this? How many of your patients on ECMO will land up in lung transplant?
So, sir, the actually institution of ECMO for a particular patient depends upon the pathology for which the ECMO has been, for which the ECMO has been instituted. So, ECMO has been classical. Like if the patient is having an end stage interstitial lung disease, or any patient or end stage lung disease which is progressing, and the patient
It's more used for a bridging.
Yes, it is bridge. Is the idea there is to institute patients on ECMO as a bridge to transplant. So these ILD patients who are having an active exacerbation who may benefit from a transplant, we can buy time by placing them on ECMO, and on ECMO we'll be doing their preoperative rehabilitations. Most of the times for a patients who are being bridged to transplant, we tend to extubate the patients and keep them more active and more cognitively active as possible. The second scenario is that the patient might be having some degree of ARDS for which the patient was instituted on ECMO as a bridge to recovery. But because of the severity of the illness and everything, these patients might be requiring, or they might not be responding to ECMO supports. So even in spite of ECMO support, the ARDS does not resolve, and then they will be bridged to transplant. So these people will be referred to transplant little late, and they will be already on ECMO for quite some time. So this particular subset of populations, we will anyway, a patient who is having viral or bacterial pneumonia and ARDS, the idea is always to put ECMO as a bridge to recovery. So if that fails, then we can always offer them an option of a transplant. But the path in this second scenario is a little more challenging, given they will be on ECMO for quite some time and they might have lost muscle mass. Their preoperative rehabilitation potential is significantly low. They will be on tracheostomy. There might be some muscle weakness. But patients who are already bridged to known bridge to transplant, we take care that they are fit for transplant. And
I think those kind of doubts and questions came after the COVID.
Exactly.
So actually instituted ECMOs on COVID patients, and we got stuck there. Either they are not improving, or they are all stuck onto the ECMO. So I think those questions. Anything to add from Chetan on that?
Until the pre-COVID thing, ARDS was a contraindication for transplant. Only after COVID, people started actually trying transplant in ARDS. They've come up with some success, and now ARDS is considered a relative contraindication for lung transplantation, depending on the center where you're doing it. So as I think the second part of the question is any specific markers at the start of illness. I think the specific marker is the pre-existing illness for which you have initiated ECMO. Have you initiated it for pre-existing lung disease or altogether new disease where you have bridged it for recovery? And as Charan sir said, if it is ARDS because of viral or bacterial infection, you have to wait at least for 4 weeks, by which time there is enough damage that is happening with the physiology of the body, and the outcomes would remain poor.
I think I could see a week back we were all discussing to transplant this recipient, and now I'm happy to see this patient walking around and off oxygen and mobilizing. A big congratulations to the whole team, including Balasubramoniam sir, Manjunath, Chetan and Charan, and the whole transplant team. I do understand that includes nutritionists and supporting teams there. And we were talking about a group of team members working together cohesively, constructively to make these patients away. We wish all of you many more such patients to bring. There are a lot of compliments, messages across the globe. So we congratulate all of you. And it is a privilege and honor to actually invite and make you all available here. Thank you for being here, Balasubramoniam sir, Manjunath and Chetan and Charan. And thank you, Charan, and bringing this.
Sir, one more minute. Dr. Vijay sir also joined. I think he would like to ask something.
Yeah, please switch on.
Vijay sir.
Hello.
Yeah, sir, please go ahead. You
Good evening,
can
sir.
switch on the mic, sir.
Yeah, the mic is on, I think, sir. Can you hear me?
Yeah, please.
Yes, sir. we can hear you.
Yeah, first of all, congratulations all of you for a wonderful outcome. I just had one quick question, sir. Like, once, how many of these patients who are on ECMO for various reasons in the intensive care will end up in a transplant? And an adjunct to this is, are there any specific markers in the initial part of the illness which will tell us that, yes, this patient is heading towards a transplant in due course of time, so that we are alarmed about the things?
I think Dr. Charan and Dr. Chetan were trying to answer that, sir.
Yeah, they touched upon that one. Yeah.
Yeah, so what the way they're saying is, why are we institution ECMO? See, one area is where the patient is an end-stage lung disease. For example, extensive ILD into a end-stage lung disease where somebody is not able to oxygenate and there is no reversibility in that. So he is into the end stage, waiting for a transplant, and he decompensated. And the only way to keep him alive is bridging to a ECMO and waiting for a transplant. So 100% of them will go to the transplant. Otherwise, they will be on ECMO or they will succumb to that. So
Yeah.
that's one category. The other category is you are initiating ECMO to for a indication where there is a reversibility. For example, we saw ARDS is the other commonest indication for ECMO. So that's what I'm trying to point out.
Yes.
And most of the times, this is a bridging to recovery, not bridging to transplant.
Right.
But at probably they're saying after 4 weeks of ECMO therapy, if you are finding the lung not resolving, and that is the point, as Dr. Chetan said, they will consider whether there is any reversibility of the lung or not. And these ARDS patients, what we have seen with influenza or any bacterial pneumonia, most of them never landed into a fibrosis, what we have seen with COVID. COVID was a different ball game where we have seen extensive lung fibrosis, which kept on being there. And that may be one of the indications after a month or so. Coming to the markers, I think Chetan is trying to answer that. There were no specific markers which can actually guide you and tell you that at any point of time that these patients will need transplant, this patient will not need transplant. Am I clear that Chetan and Sricharan, or anything to add in that?
Yes, sir. Yes. Clear, sir. So
Very clear.
Sir, anything, Vijayawada, sir? Anything?
No, sir. Thank you, sir. Thank you very much. Thank you.
So I think we had a wonderful discussion, wonderful session. Thank you, Vijayawada, sir, in bringing those questions and making those areas also clear. And I thank all of you in being a part of this program, and I congratulate all of you. Wish you many more such success, patient outcomes and transplants. And best of luck for all of you for the near coming future. The transplant program, that to lung transplant, is a complex challenge. The whole world is looking after this. Maybe we will be one of those very few centers in India who will be doing this. And we wish you all for excellence in that forum. With this, I conclude the session. Thank you all for being here for today. Thank you.
Thank you, sir.
I conclude the session. Thank you, Balasubramoniam, sir.
Thank you.
thank you, sir.